I'm Dr. Erika Hamilton from Sarah Cannon Research Institute in Tennessee Oncology. On behalf of my steering committee members as well as co-investigators, I'm pleased to report the analysis of Monarch E by age in terms of efficacy and safety. As we know, patients that have node positive disease can have up to a 30% recurrence at the 5-year study time point. Monarch E is the only study to exclusively look at risk reduction only in patients with high risk. In the initial data, in terms of invasive disease-free survival, at 2-year follow-up, we saw a 2.8% benefit with the addition of abemaciclib for 2 years. When this increased to 4 years follow-up, our magnitude of benefit also increased up to 6.4 years. We saw a similar pattern in terms of distant recurrence-free survival. At 2 years, the benefit with abemaciclib was 2.5%, and this widened to 5.9% at 4-year follow-up. Briefly, Monarchy was a trial that enrolled over 5,600 patients that were either receiving endocrine therapy or received endocrine therapy in combination with 2 years of abemaciclib. Everyone then went on to receive somewhere between 3 and 8 years of standard endocrine therapy per physician and patient preference. In terms of those patients that were less than 65 years of age and greater than or equal to 65 years of age, this cutoff was used in the analysis of Monarchy because only 3% of patients were 75 years or older on study, really precluding good analysis of this population. Invasive disease-free survival and distant recurrence-free survival was no different between younger patients and older patients. A 6.7% benefit in invasive disease-free survival for less than 65, 5.2% benefit for those patients 75 years of age or greater, and with distant recurrence-free survival, again, a 6.2% benefit for less than 65 and a 4.6% benefit for 65 or greater, non-statistically different. There was not even a numerical increase in neutropenia, ALT elevations, venous thromboembolism, or ILD in older patients compared to younger patients. Numerically, there was actually a decrease in any grade diarrhea for older patients compared to younger patients, but grade 3 or severe diarrhea was a bit more common, 7% versus 12% in the older patients. Similarly, grade 3 fatigue was also a bit higher, 2% versus 6%. We saw 41% of younger patients have a dose reduction and 55% of older patients. Similar pattern with discontinuations, 15% in younger patients and 38% in older patients. What was surprising was that we saw over half of the discontinuations, whether we're talking about younger patients or older patients, occurred without any attempt at dose reduction first. To reassure us that dose reduction is appropriate and does not impact efficacy, a relative dose intensity analysis was performed where patients were split equally into 3 groups based on their relative dose intensity of how much abemaciclib they got compared to the starting dose of 150 milligrams twice daily. There were no differences in efficacy in all 3 groups. Quality of life, as measured by FACT-B, showed no differences by arm of abemaciclib or not, or by age, younger or older. Again, in Monarch E analysis by age, we saw benefit in all age subgroups. Older patients do have more comorbidities coming into study and sometimes can have poor health status at baseline, but the AE event rates were actually quite similar. We did see more reductions and discontinuations in older patients. And when I look at the data, it really stands out to me that over half of the patients that discontinued drug did so without any attempt at dose reduction, really underscoring our ability and need to counsel patients regarding this and utilize dose reductions more frequently. Thank you very much.